I think that this is probably one of the more important topics that physicians should know about, and also hospital leaders. This is very, very pertinent to how we practice medicine. And I speak now as a physician who's in the trenches on a daily basis. So my next question is, why do you feel it's important to bring the work of the IHO to the fore at this time?
What's the problem the hospitals experience today? Unaffordable cost, really thin margin, sometime on the red, and frequently getting out of business.
Yes.
Second, our emergency departments are overcrowded, dangerously overcrowded, because there were tons of publications showing that results in increased mortality. We are talking about overcrowded EDs, and that's where the pit comes, the show pit comes from.
Yes.
And everybody is giving applause to this and excited about the show, myself included.
Yes,
I think it is amazingly good show.
Absolutely. I have begun to watch it myself with my spouse, and we are glued to the screen when this show is on TV. It's an amazingly true, accurate program.
Exactly. The only problem I see with the pit, that it was timely 10 years ago, it is timely now, and it will be timely in 10 years unless we do something in healthcare. In 10 years, we can show the same thing. Unless we improve patient flow, we will see the same show and believe that it has been filmed yesterday. Then nurses and physicians burn out and leave in the hospitals. So the shortage of nurses becoming worse and worse. Last but not the least, the number of avoidable deaths is very high, measuring in hundreds of thousands avoidable hospital deaths. If I may, I would like to show one side.
Yes.
I would talk about hospitals at this moment.
Yeah.
This variable line is the line of the hospital bed occupancy census. And this is the photo or the plot of pre-COVID hospital. And that is a real hospital. Mm-hmm. That I call this hospital, when they ask me what the name of this hospital, I say I call it not my hospital.
Right.
Because nobody wants to acknowledge that that's a case. And yet it's a case at practically every hospital. So what does that mean? What do we see on this plot? The red dashed line at the peak level of hospital bed occupancy, that's how we staff beds many, many years, dozens and dozens years ago. Nobody can afford it. Mm-hmm. So how do we staff today? We look at the budget of the last year, and let's say this is a red bold line, and we say that we will staff next year on that level. Mm-hmm. So, but the average census is never the case. The average census is meaningless. It's like an average temperature at the hospital. It makes no sense and gives no benefit.
Right.
So what happened in this case? And that has been documented in multiple publications, and I am not a co-author of either of them.
Uh-huh.
It results when you have a peak above this red bold line, today's staffing, we have medical errors, readmissions, overcrowding, infections, elevated mortality. And that's a reason for demand for nurse staffing ratio. That's why nurses demonstrate. Right. They don't want, when they staff on this red bold line, they don't want to staff to take care of the patients at the peak level. They're just not capable of that.
Right.
And the mortality would increase. So what I would like to say, as long as we have those peaks above the red bold line, we will have all these consequences in the right corner in the red font. No matter. I don't want to minimize the importance of what hospitals are doing today. AI, other things, which are absolutely needed. But I would tell that there is a prerequisite. As long as you have this peak above this average staffing level, red bold line. You will have all these red fonted consequences in the upper corner, right corner of the plot.
Right.
No matter what else do you do. If you talk today to any hospital, they say, oh, we always have a peak. We always have 100%.
Yes.
100% bed occupancy. That's not the case. If you will always have 100% of bed occupancy, you will never be able to perform any emergency surgery or admit a patient from the ED. There would be simply no room for them.
Right.
There is no science in managing patient flow. So the idea is to smooth those peaks. As long as we have those peaks, we will have these consequences. So we have to smooth those peaks. If you go on the street and ask a stranger, describe the hospital. Typical hospital has more than 50% admission through the emergency department. That's a main portal to the hospital. The next one would be scheduled admission. Mostly surgical, but it could be cath lab as well.
Right.
So if you ask a stranger on the street, what is the main reason that we have those peaks? They will tell the emergency departments. Because the volume is higher and their admissions, their arrivals to the emergency department is not predictable. Quite to the contrary. That is not true. Again, they would provide this answer based on the common sense. But we know already that the common sense and the healthcare delivery is not compatible today.
Right. Right.
So that is why the answer is that those are elective admissions. They are more variable than arrivals to the emergency department.
Yes.
What does that mean? That it is easier for somebody to predict when somebody will break leg and come to the emergency department than when elective admission will take place. That's far from being scientific.
Absolutely true.
That is in our hand to smooth those peaks and valleys.
Right.
By the way, there is a published study of the entire New York State of all 1.6 million admissions. And they compare admissions through the ED and compare admissions, scheduled admissions. And in the plot, you can see obviously that admissions to the ED are pretty steady state during weekdays. If you come to the ED today and short of epidemic, bus crash or whatever, and ask nurse manager, 5 Tuesdays from now, how many patients would be admitted? Again, short of the bus crash in front of the hospital, they will give you pretty accurate number, not exact, but pretty close. If you come to figure out how many scheduled admissions are going to take place in 5 Tuesdays from now, I doubt you will get the answer.
That's interesting. Very interesting.
And the hospital C-suite are afraid of smoothing. They believe that if they will come to surgeons and say, we want to change your block time distribution, then the surgeons would push back and may go to another hospital, and the hospital will lose revenue, and the hospital C-suite, that may cost them job.
Yes, yes.
However, that's not true. That's a myth resulted from ignoring the science. Surgeons are the main beneficiaries, they and their patients. They get bigger paycheck, they have significantly lower overtime, they have fewer deaths and medical errors, etc., etc.
Yes.
So I want to stop at this point, otherwise I can talk for another few hours.
Yeah. There's a book about you and your life who people who are watching this podcast can get a hold of in bookstores and via Amazon. And can you tell us briefly about this book?
That's a book.
There it is.
You mentioned.
Yes, Hospital Heal Thyself.
Yeah. The author is Mark Taylor. I always, when I talk about this book, to be able to promote it, because I really like it, I always say that I am not taking a penny out of the proceeds of selling this book. That allows me to be objective.
Yes.
The author interviewed leading people, the former head of CMS, the former head of Institute of Medicine, many hospital CEOs, surgeons, nurses, patient advocates. And the answer was uniform, that it works at every place.
Yes.
So I think it's beneficial for those who want to introduce it, for the C-suites.
Yes.
I can tell you personally, it is beneficial to myself.
Yes.
Because I gave it to my wife to show that I'm doing something useful in my life, you know.
Okay.